Welcome to Case of the Day. This is Dr. Bhavin Jankaria, and we've made it to the 14th case. And this is titled the SIFK and MMPRT phenotypes. SIFK stands for spontaneous insufficiency fracture of the knee, and MMPRT is medial meniscus posterior root tear. So this is a 51-year-old, mildly overweight lady, presents with a 2-month history of pain, no history of obvious trauma. And if you see the coronals from anterior to posterior, you can see cartilage thinning and fraying. There's meniscal extrusion. There's a lot of edema around the MCL, marrow edema, this thin low signal or hypointense line paralleling the articular surface. Again, extrusion, MCL edema, marrow edema, and this tear of the root of the posterior horn of the medial meniscus. If you look at the sagittal images, we see the low intensity line parallel to the articular surface and the marrow edema, cartilage thinning anterior and mid portions, and the absence of the root, which tells us that there's a root tear. And on the axial images, we see the bone marrow edema, the ligamentous edema, and this classic tear of the root of the posterior horn. So if you look at it from the perspective of the horizontal line and the marrow edema, this is classic spontaneous insufficiency fracture of the knee, and some people put it as insufficiency in brackets stress fracture of the knee. If you look at it from the perspective of the root tear, then we have these three classic signs. The sagittal ghost sign, where when you're following the meniscus, suddenly you don't see it. It's as if the meniscus has ghosted you. The coronal cleft sign, which is very obvious, and the axial radial defect sign, which is also quite obvious. And typically, we can appreciate all these three signs or two of these three signs, but when present, then the sensitivity and specificity is very high for a medial meniscus posterior root tear or the MMPRT. Now, if you look at articles, and this is a 2019 article on SIFK, and very, very long, elaborate article, but at the end, they say that for high-grade SIFK lesions, the surrogate markers are MMPRT, chondrosis, extrusion, and a greater degree of perilesional soft tissue edema. And then if you look at articles that talk about meniscal root tears, and this is from 2023, they will say that the secondary signs are extrusion, subchondral insufficiency fracture, and then here is the phenotype, greater than 50 years old, usually women, no history of high energy trauma. So depending on where you start from, you can either assume that MMPRT is the main lesion with associated cartilage thinning extrusion and SIFK, or you might, when you're reading, start with saying, oh, SIFK is the primary pathology with associated MMPRT and other findings. Irrespective, the phenotype is the same. Women more than men, greater than 50 years of age, low intensity to no trauma, mild overweight to obese. You find MMPRT, bone marrow edema or SIFK, meniscal extrusion, cartilage thinning, and mild to moderate OA. And what they don't mention but often we find is MCL thickening edema or periosseous edema. Basically, when we read MRs in men and women above the age of 50, if we see one of these in the correct clinical setting, look for all the other signs and report them together. So there is a tendency to just report all the findings again, listing them one after the other. No, report them as if this is a disease entity by itself, like we would report an interstitial lung disease or a tumor or AVN, etc. So this is a phenotype, and a good way to say this is that there's reduction in the cartilage in the medial femorotibial compartment associated with signs of SIFK and MMPRT or tear of the posterior horn of the medial meniscus root, etc. And just put it together in the conclusion so that the referring orthopedic surgeon is able to understand what we're talking about. What happens after that, treatment management, that's not the purpose of this talk. So that's my WhatsApp channel, and thank you so much for, viewing this and listening to me. And, comments are always welcome.